Good afternoon. Welcome to our Facebook Live session. We appreciate you all joining us. This is Longstreet's 5th Facebook Live session. During this interesting time, this has been one of the things our team has really enjoyed doing. And we hope today's session is informational and helpful to you. I want to introduce the team members that are joining me. We've got today Vicki Trusty. She is one of our nurses and our population health manager. Christie Payne, there's Christie. Christie Payne, our contract analyst and contract director. And Marti Gibbs, family physician, chairman of our board, and recently elected our president of the clinic. So thanks, Dr. Gibbs, for joining us as well. We wanted to talk to you today a little bit about what it's been like for the clinic as we've gone through the last several months. It's certainly something none of us have ever been through, and it has been a journey for sure. Beginning in mid-March, when all of the pandemic was announced and the emergency orders put in place, we moved into gear very quickly. Our physician leadership called meetings that weekend. We had them all day Saturday and all day Sunday with the management team, providers, and physicians. We made decisions about cutting back hours, what clinics we were going to continue to run, how were we going to manage the patients that we care for in the hospital, such as obstetric patients, neonatal patients in the NICU, newborns, and surgical patients that are in the hospital. We also reviewed the CDC guidelines, American College of Surgeons guidelines, and other specialty specific guidelines, and made decisions consistent with those. And pretty much after that weekend, we rescheduled or delayed all scheduled surgeries, and we started moving into action that Monday. We set up a command center and a COVID response team. The COVID response team staffed the command center during normal business hours, and then certainly on into the evening and on weekends there at the beginning. That allowed us to centralize our response internally to decisions, questions that we had from team members. The guidelines that were happening were coming out very rapidly, so we needed to have that team in place, helping us navigate those waters during that time. We also centralized our PPE, personal protective equipment. We, like most hospitals, were struggling with having enough PPE in place, even as we were delaying opening, changing hours, and making changes to our schedules. We also looked across the clinic at any procedures and diagnostic testing that could be any adverse outcome to patient care. So for example, we shut down a number of our diagnostic imaging services in our imaging department, including mammography, very quickly. Now, as we move forward, we wanted to talk a little bit about that experience and share with you how we're doing today and what we're doing to prepare. And actually, as we have begun what we are calling our ramp up or open up strategy, as we are beginning to get somewhat back to normal in our daily lives here at the clinic as we're taking care of patients in the community. So first, we thought it would be good to start off talking about how we've managed patients that are concerned that they may be sick with COVID or have symptoms, and how we treated those patients and how we've gone through that process. And I thought we could start with Vicki and Dr. Gibbs sharing that experience with how do we identify patients that may need to be triaged or tested for COVID, and then how we go from there.
So first of all, COVID is a new virus to us. It's a coronavirus. Coronavirus has been around for years and years and years, hundreds of years. But this particular virus is a brand new virus that our immune systems have not encountered. So the immune response can be more severe, and that's what we've been battling. But as we've gone along, we've learned a lot in the process, and that's equipped us to make better decisions. So it's a new virus, and our immune responses, are can can be a little more challenging, but I can tell you what the coronavirus is not. It is not a conspiracy theory, and it is not the flu. So, you know, in the beginning, I heard lots of chatter about it being conspiracy theory or the flu. I will tell you it's different than any virus that we've ever encountered. And we see that in those sickest patients. But the majority of the patients that have COVID actually can be managed in the outpatient setting. They present with just various symptoms. So typically about 10% of the patients that we test for COVID are positive. So the majority of patients that have those COVID symptoms, the majority of those patients actually do not have the coronavirus. So in my clinical and what I've seen in practice, I've treated probably between 20 and 40 patients with COVID, and I've probably had less than 5 patients that actually ended up in the hospital. 2 of those patients were fairly severe and ended up on the ventilator. So, but by far the majority of the patients are treated in an outpatient setting and can be managed that way. So, and as far as the treatment's concerned, it's very supportive. And the great thing about our team is that we've really grouped together and have been able to touch base with these patients that have been diagnosed with COVID along the journey and helped reassure them in that outpatient setting. We give them the warning signs, what to watch for as well.
I know that here at Longstreet, what we've done with our positive patients too, is we've centralized how they're handled. So when we have a positive patient, the care management team makes sure they're connected to their PCP. If they don't have a PCP, we make sure they get connected to someone so that they're followed and they have the follow-up care that they need. They're managed well. They have someone to rely on or call when their symptoms worsen. And then they also have someone that they can follow up with to get a good back to work plan so they can get back to work after they heal.
Vicki, how have we handled treating COVID positive, or how have we, once they're diagnosed positive, how do we make sure that we're protecting them and the rest of the patients in the clinic?
Most of the time, if we have a patient who's positive for COVID, they probably don't feel great. So, and not only that, but they're under isolation. So that means staying in the home, safe, away from others. And so what we do is we've developed telehealth visits, and we set them up for those. So if they're discharged from the hospital or they're tested positive, immediately we come up with a follow-up plan for those. Go ahead and do that appointment for a telehealth, or it's commonly known as a video appointment. So they can do that in the comfort of their home.
And Christie's going to talk a little bit more about that later on in our call, about how we see telehealth evolving in our ongoing care delivery process here at the clinic. So we had employees test positive. Vicki and Dr. Gibbs, why don't you tell us a little bit about that experience?
We've had a handful of employees that have tested positive. The majority of the exposures for that were actually outside of the clinic. So even as we care for our community, we've been able to keep our workspace very safe, and we've taken those precautions. I think it's a testament to the great job that's been done to keep our environment safe and clean. To have so many employees and only have a handful that tested positive is just extraordinary. I think it's a job well done.
Mm-hmm.
One of the important things I think we did with that is we quickly centralized how employees would be taken care of when they had exposures or concerns about being exposed to COVID or having COVID. So the care management team handled those and quickly got them the care that they needed, as well as followed them if they were COVID positive. And as you said, we handled all of the COVID positives outpatient.
Right. And we've continued to really stay on top of screening all of our employees as well as visitors as they come into the clinic. This helps us identify people that may need evaluation. And as Dr. Gibbs said, most of those are not going to be COVID positive, but it has allowed us to identify people that may need an evaluation and explore with them if they've been exposed. And so we continue to do that today. You know, both of you have talked a little bit about testing. And so one of the things that we get questions about, I know I do in the community often, is what is all this about testing? Why does it take so long to get results back? What's a PCR test versus an antibody test? And are those tests covered by my insurance? So why don't we start off, Dr. Gibbs, with what is the difference between PCR and antibody test? I will tell a funny story. One day we were in the command center and Vicki was in there with me and one of our nurse practitioners. And I was very confused about all the different testing information being an administrator. And I got a pretty good lesson on the difference of PCR and antibodies and IgMs and IgGs and all kinds of stuff. But will you give us the thumbnail sketch of what's the difference between a PCR and an antibody test?
Okay, so immunology 101. Okay, so the PCR test is really to test whether you have an active infection or not. So everybody has talked about the nasal swab. Okay, they're going to tickle your brain with this swab. That's the PCR test. So that helps us test to see if a patient has coronavirus at this point in time. So, so that is truly a positive patient. Now, the antibody test is more a reflection of whether your immune system has encountered it in the past. So it helps you know whether you've had this COVID-19 previously. Like we've heard in the community, oh, I think I had it back such and such. Well, if you had it in October or November, you did not have it. But if you had symptoms like March, something like that, sometimes we can order the antibody test to help us know whether that particular infection was indeed COVID-19. So it's more of a measure of whether you've had it, not that you currently have it.
Great. That's every time I hear it, it helps me understand it. As testing has evolved, Vicki has been very involved in monitoring all our COVID test positives, negatives, and how that's evolved from the beginning. I think everybody knows and has heard about the problems that we all had at the beginning. There was a limited supply of swabs. Unfortunately, there were a limited supply of the nasal swabs. So we had to use other types of swabs that are not even as comfortable as the nasal swab is. There was a ramp up challenge for the lab vendors that were actually performing the tests. And all of that added to a pretty awful turnaround time. Obviously, if somebody was not feeling well and was sent home to isolate, sitting around and to find out whether you were positive or not created a lot of anxiety and stress. So, Vicki, why don't we talk a little bit about what that turnaround time looks like today and how we're doing with testing, particularly for the PCR test?
Well, first, I want to give a shout out to our lab. Right from the beginning, it was decided that we would have a core group of technicians who would do that test to ensure it was as accurate as possible, and they have been. And up to date, we've run about 2,500 tests, and so that's a lot for that crew to be handling. So in the beginning, they were geared mostly towards those who were sick, definitely showing symptoms. And so our rate looked abnormally high, but as the testing became more available, and even now we've got the need for tests for those who take care of elderly parents. People are going to camps, people are going back to work. So with the availability of the testing, we're able to test asymptomatic patients as well. And so our numbers are normalizing to reflect more of a national 8%, a little over 8%. So it reflects where we're at with that national number as well, with those doing more testing.
In addition to those, that 2,500, we also have been doing the PCR tests for patients that are scheduled for a procedure. So of that population, the positive rate is only 2%. So again, showing the expanded testing and getting more people tested gives us a better sense of what the overall disease prevalence is in our community. Speaking about procedures, why would we need to test people prior to a procedure?
Well, the main reason why is you're going to treat a patient with different preparation or PPE if they do have COVID. It doesn't mean that the procedure is going to be canceled. It just means that we're going to need to be more prepared in order to prevent others who are doing the procedure contracting COVID.
And that includes obstetric patients, women who are preparing for delivery. That was when we implemented that, it was certainly a lot of communication to those women having no symptoms and early on, and again, another stressful thing for them to go through. But by doing that, we can make sure that when they present for delivery, if they are COVID positive, that the physician, the nurse midwife, the hospital is all prepared to care for that woman and her baby in the best manner appropriate. So we've talked about all these testing, and all that comes through to, okay, well, how much does that cost a patient? Christie, being over our contracting and reimbursement arm, talk a little bit about how carriers are covering COVID testing.
So all the insurance companies and Medicare are covering COVID testing and any COVID related service at 100%, or they're waiving the patient's cost share. What is a cost share? It's the patient's portion, and it can be referred to as a co-payment, a co-insurance amount, or unmet deductible. And even for those patients that maybe have lost their job or they don't have insurance, the patients that are uninsured, these services are available to them at no cost. We have the capability to file claims under the CARES Act. It provided reimbursement for these services for providers.
And so we are actively using that method for our patients that are uninsured, right?
Yes, we are.
Okay. So before we leave the testing, we talked about antibody testing, and that's a super hot topic right now. People that want to be tested to see if they have antibodies and what that means and what it doesn't. I'll share that our last Longstreet Clinic board, we had a pretty heated, active discussion about the role of antibody testing. So Dr. Gibbs, why don't you share with our folks what the antibody test means? If you get it and you're positive, what does that mean?
Okay, so if you get the antibody test and it's positive, it basically tells you that you've had the virus previously. So you've had COVID-19. But what does that tell you kind of going forward? It does not, we don't really have any studies to tell us whether it really provides immunity for you or not. So our biggest fear, I would say, in patients requesting the antibody test is if they are positive, that they'll kind of relax, that they won't wear their mask, that they won't do the things that they should do to protect themselves. And I think that's a very real danger. All it does is tell us that you've had the virus before. It tells us nothing at this point in time about your protection going further forward as far as protecting yourself against COVID or having it in the future.
Yeah, I feel like it's a false sense of security in some ways.
Yes.
Yes. We did mention earlier about turnaround time when we started and the challenges, but just for everybody to know, today that supply chain and supplies are more readily available, and the platforms that run these tests are now up and operationally efficient. So we've gone from a turnaround time at the beginning of as far out as 10 days, 7 or 10 days, which again is a long time to wait when you're sick, to a turnaround time of usually 2, sometimes 4 days. So much better turnaround time, and certainly something that's important, particularly for those surgical patients, because we want to test them as close as we can to their procedure, because that test is a point in time. It only says you are positive or negative. So we want to make sure. So now we've told you the story a little bit of where we've been and where we are now on treating patients and testing. Over the last several weeks, we have been, like many businesses and certainly healthcare organizations, have been planning and working towards our opening up strategy or ramp up strategy. Starting May 18th, our surgeons were able to begin to go back to perform scheduled surgeries. And we have been several weeks maybe before that, began opening some of those services that we had shut down, like mammography and imaging studies, and beginning to talk about opening back up to our regular hours. We just last week opened our urgent care back up to their normal hours of 9 p.m. at night during the weeks and on Saturdays and Sundays. And we've been running much shorter hours then. So what we've used is a guideline that was put out by the American Medical Association specific for physician practices on the strategy for how to open up. And we've been using that along with CDC guidelines, American College of Surgeons, and other sources to plan our opening up strategy. Having so many different specialties in the clinic means we had to think about it differently for each one of our specialties. So we've needed to use all those resources as we've worked on the plan. So one of the things that we have been working on that I want Vicki to talk about a little bit is how do we keep the clinic safe and clean and make sure that it's safe and appropriate for people to come in. And also talk about Dr. Gibbs and Vicki talking about what kinds of care did we delay, and should patients continue to delay care, or is it appropriate for them to come back to the clinic?
I'll go ahead and start off with, we quickly, when we decided to ramp up and return patients to getting their usual care, we knew quickly we were going to need to develop a plan to keep the patients safe and the staff safe. So there's a policy that all staff members have to wear a mask while they're at work and in the building. We also ask that all patients wear a mask when they come in the building if they don't have it. We've
including
got some
visitors.
Including, yeah, I'm sorry, not just patients, but anyone entering
Everybody.
the building.
Mm-hmm.
And that includes anyone who's here to deliver a product to an office, UPS, everybody. The other thing that we do is we get temps on everyone, and we also do a COVID questionnaire on everyone who comes in. It delays their ability to come in quickly, but we get through it very, very fast and get them on their way. And then on the floors, they're doing more frequent cleanings. They're also cleaning between patients. And then our cleaning staff also are cleaning more frequently those areas that are high touch.
I do have a funny story. One of our administrators came to our office. It was right in the beginning where we were beginning to see patients back in the office. And she thought I think she maybe thought she'd test it out a little bit and see if she could kind of sliver in the door and not go through the screening. But I think one of our staff members just came running down the hall and almost tackled her to get her back to do all the screening before she came in the building.
I wonder who that was.
It wasn't me.
Well, that's not you.
So I was just going to say, we also have put up, the plexiglass at the front desk because we weren't able to provide them with, the N95 mask, but at least we were able to put up the plexiglass stands where when they're interacting with the patient, they feel protected as well as the patient as well.
Yeah.
Right.
So we really had to make that
So,
decision in
as
the very beginning about delaying care for some patients. So those
Right.
types of things that we delayed were like the mammograms and the preventative visits, colonoscopies, those elective procedures and such. And now that we have a lot of those safety precautions in place, and now that the curve has flattened to a degree in our county, in our area, I think it's safe to begin to really ramp up and offer those services again. And I also personally feel like it's really important to do those things, because if you delay, getting your mammogram for 6 months, make a difference. And I've even had patients, personally, who really just didn't want to come into the office, that just delayed care, and then they ended up with an emergency room visit. So it's important at this point in time, because I think when we're looking at this pandemic, you've got really two sides of the equation. You've got the pandemic, but we have a lot of chronic patients and ill patients that need to be seen in our office.
Right. I looked at an article earlier today, actually, that talked about the challenges people are having because of the economy, whether they've lost their job or, just the whole economic situation. So Christie and I have seen some information from some payers that are recognizing that, some insurance companies, providing some incentives for people to come into the office to get their preventive and needed healthcare services, right, Christie?
Correct. Most insurance companies are, again, waiving their co-pay, co-insurance deductible for patients to get in, because at times that can be a barrier for patients. So they've recognized that, and they do want you to come in and get your preventive care and your chronic under management.
Right. And before we leave this subject, I do want to stress again how seriously we're taking visitor policies, safety and security measures. Our team really has stepped up and worked really hard to make sure that during the period of time we were in a slower position, that we were building our PPE supply, developing these strategies. And we have just modified our visitor policy again this week. We expanded our visitor policy to allow all patients to bring in no more than one person with them. Before that, we had a tighter policy. So we are getting more comfortable and moving in that direction. But Christie, while you're on the hot spot, we talked a little bit about telehealth already. Why don't you tell us about how we deployed telehealth, what it helped us do? We'll talk about that for a few minutes.
Sure. I mean, what is telehealth? It's considered really an audio video visit between a provider and a patient, face-to-face visit. Historically, telehealth was, limited to rural areas and had a lot of rules and restrictions. So when the pandemic hit, the president put out a waiver allowing us to use different modalities to, deliver care with different methods. And we started out, I think, with like using FaceTime if patients had a smartphone, using Zoom, using DoxyMe. There's all kinds. But we really were focused. We really wanted to get focused on a secure platform. We had underutilized our patient portal. We went live with the new IT platform last year. So we didn't really roll out My Chart, which is the patient portal. And it is a cool thing. You can, manage your appointments. You can, talk with your provider, and your provider provider's office. You can request refills. You can update your medications and your history, your allergies. It's really a cool thing. So if you haven't signed up for My Chart, I would say do that. That way it prevents delays in communication. So we were able to use that integration where it was secure and we could actually have a video visit with the patient. Of course, there were some patients that we couldn't do that with. I have a funny story with my father. He has some chronic conditions and we reached out to him to get him to do a video visit and what we were saying, and he hung up on us. So I had to say like, okay, this is what we're trying to do. Then I think Vicki has some great stories about how they, we had to work on our communication to let the patient know what we were trying to do. And not only that, some of our physicians struggled. Some of our computer savvy ones did. I think it's much easier to see a patient in person than it is to figure out, are they using FaceTime? Are they going My Chart? So it was a whole new workflow for sure. And they had to set a time. It wasn't like they could see patients, every 20 to 30 minutes or however they fixed their schedule. It took more time. And as we got to doing it more, we got better at it. Yeah. So I don't know if you want to share, Vicki, what y'all strategy was in trying to get, the patients connected with us.
Well, to tee off from what you said earlier about it was difficult for some patients because when you said video, they're thinking they're handing or holding in their hand a video camera and videotaping. So a lot of them were like, I don't have a video camera. So we just had to say, well, can you see YouTube or FaceTime? Or do you have a family member who can? So we worked through that. But on another note, telehealth has been invaluable. I know we really wanted to do it before we were ever able to, and this has just been has increased the ability to do it. So one of the things that we use it for is hospital follow-ups. Those persons who are still vulnerable and don't need to come into the office and risk exposure, we can do telehealth for those. Another thing that we frequently use telehealth for are those patients who we test and are positive, and we need to follow up with them, but they are still under isolation, and I mentioned that earlier. We use telehealth for those to get them to a point where they're safe or come out of isolation. We're able to use it for consultations. There's just a lot of uses for it. It doesn't replace the patient's care plan, but it's a good tool to add to it.
Dr. Gibbs, how do you see telehealth evolving long-term in the clinic?
I think this has been extraordinary because it's kind of opened our eyes to the use of this going forward. So in thinking about my patients that I see, certainly my patients that still are really at high risk if they were to contract COVID, those are the patients we really want to protect. So like our COPD patients that are on chronic oxygen that have a lot of underlying issues, I really see it being beneficial for those types of patients. Another type of patient that I've really felt like it's been beneficial for are the mental health patients that are struggling with depression or anxiety, which honestly at this point in time is the majority of patients that I talk to are struggling in some way, shape, or form with those issues. So I think that's going to help improve compliance with our mental health patients. It makes it easier. I've seen already that those patients the follow-up has been much more streamlined and they've been much more compliant.
So even though it's a great technology and it's great for those very specific events or in patient care needs, it's also not good for everything, right?
Right. So like there's nothing like you think about your annual wellness visits and those things, and we've kind of, puttered along for a little bit, trying to do the best we could for those patients. But really, our annual wellness visits and preventative medicine, those patients are better served coming into the office so that we can care for them and really do their full exam. Also, our chronic patients that need their lab monitoring, our diabetic patients, those patients, they're better served coming into the office so that we can check that blood work, so we can make sure that they're on track. And then the other thing are like problem visits. A lot of times those are better served seeing in the office. Right now, the way we're handling things, sick visits, we try to do those at least initially through telehealth if they have symptoms of COVID. But a lot of other things like rashes and such, sometimes it's best to see those patients in the office so we can assess them better.
Right. And I think the governor in one of his press releases or press conferences mentioned that there's some state data that says that we have had a drop in cancer diagnoses by, I think he quoted 30% in the state, which we know cancer hasn't gone away, but Dr. Gibbs is probably because of exams and visits and preventive care, right?
Right.
So one question that we've all talked about, and I know everybody that's listened and has talked about this too, is this going to go away? If we had a crystal ball, when are we going to go back to our normal? And how do we deal with that? So Dr. Gibbs, what do you think about, are we going to be living with this for a long time?
At this point in time, we heard a lot of theories that in the summer it was going to go away. We're still seeing new cases in our community, but we're not seeing them at the rate of rise that we saw, maybe a month or 6 weeks ago. So we're seeing improvement. So the curve is flattening to a degree, but I think it's going to be with us for a while. We've got to settle into a new normal. And that means we've got to continue to be diligent, not only in our clinic and keeping safety a priority there, but also in the community, like wearing your masks and using hand sanitizer and cleaning, frequent high touch services, washing your hands, staying the social distancing. All of those are just keys to moving forward and us all working together to minimize the spread of COVID-19.
Rest of you guys, what do you think?
I think you better get used to using your mask as an accessory.
I have one for every outfit.
Get a cute one.
Yeah.
They even make reversible ones. So.
Yes.
Well, I would just say that I think this is probably the new normal. I don't think we'll ever get back to normal. But I think patients need to rest assured that we're doing everything we can to keep them safe and don't delay their care, whether they have insurance or they don't have insurance. I mean, if they think they have been exposed to COVID or have COVID symptoms, that we're here for them.
Right.
Absolutely.
And we're ready to see our patients back in the clinic.
Mm-hmm.
We're here and we're here for you. And all of our services are back open and operational, screening mammograms, regular diagnostic mammograms, all our diagnostic solutions, as well as our practices in a socially distant, appropriate way. It's been fun thinking through waiting rooms and that kind of thing. But the team really has done a great job. Does anybody have any final thoughts for our listeners?
I would like to add too, if you're not a patient with us, our urgent care is open to everyone. If you're not feeling well, come in.
Yes. Thank you, Vicki. That's
good. And I just want to say we're all in this together.
Mm-hmm.
We are all in this together, and we can do this. And and we're doing a great job as a community. I'm so proud of our medical center and the Longstreet Clinic, and really just getting the ball rolling from the very beginning. I was just very impressed before it really hit heavy in our community. So just a job well done, and we will continue to strive to keep our patients safe and continue to care for them.
Great way to close our discussion. As Dr. Gibbs just said, we want to hear from you. We want to see you. If you have questions, there's numbers of ways to reach out to us. You know, there's the old-fashioned telephone, as well as our Facebook page, our website. You can send us a message on website. Vicky's care management team is also a great resource. You can call our regular number and ask for care management. And they can help triage and help with making a plan for any issues that you might have. We do have some resources on the website, and we would love to hear from you, see you, and as Dr. Gibbs said, wash your hands, use hand sanitizers, socially distance. I personally like physically distance instead, but socially distance, and wear your mask. I know that is sometimes a challenge. I know I've gotten in and out of the car and had to go back to the car and out of my office and back in my office to get my mask, but keep each other accountable, and we can keep this going in the right direction and take care of our community, our patients, and each other. So thank you. We enjoyed the time today. Bye.
Thank you.
Bye.
Bye.